Hi, everyone. Welcome. It feels good. It almost feels like coming home a little bit. I was away. My parents finally got to come down from Canada. So it's been a great summer in some ways. Did a little traveling, got some refresh and recharge. So missed you all. And it's great to see everyone out there and to connect this way, staying socially connected as we're physically still distanced, unfortunately. Hopefully everyone's safe and is doing well, and keeping, connected is such an important thing. As you know, my work has been focused on in the last year and a half. And I continue to, try to find amazing speakers. And thank you to the PMD Alliance for continuing to host this space and hold it for us and allow us to connect on various topics that may be a little out of the box. So today, I'm just so excited to have Dr. Janis Miyasaki, who is a mentor and a friend and just an amazing force of nature. I think she's really been a pioneer for many of the things that I've been passionate about. She's a professor in the Department of Medicine and Neurology at the University of Alberta. She's a fellow Canadian and really has just been a world leader in just championing a few causes. I think she's really been about the patients and their caregivers, about what matters to patients the most who are living with Parkinson's, and also championing the field of palliative care and Parkinson's. And so we're going to have kind of a free-flowing discussion. If there's topics that you want to try to bring in, please put them in the chat and we'll try to include them. And we'll try to, just sort of bring out I think sort of some real pearls, hopefully, of knowledge from Janis's work. So welcome, Janis. Thank you for joining us. I know it's taken us a little time because I know you're so busy. You're now, I think, really active and ascending the ranks at the American Academy of Neurology, and just have really been, sort of just an amazing career. So maybe you can tell us a little bit about kind of why you were attracted to neurology and Parkinson's, and why this has been kind of an area of interest in the palliative care world for you.
I was always interested in neurology because it just seemed cool to understand how people think, how people move, but all the unknowns. I think that's the other thing, is that there are a lot that isn't known about the brain and the brain's function. And I sort of think the other organs are kind of like dumb. Like the heart's a pump, lungs and kidneys, they're filters, liver's a filter. But the brain is like so awesome, right? And everyone's brain is a little different. The thoughts that they come up with, the things that make them excited, the things that engage people vary from person to person. And it really is part of the essence of being a human. Starts in your brain. I have to say, movement disorders, I always thought was very interesting, but I never thought I was smart enough to do it. And you may have heard this story, Indu, but I was the chief neurology resident, and I happened to be in the med room. And Tony Lang, the god of movement disorders, said, "What are you doing next year?" And I said, "I don't have plans." And he said, "Would you like to be my fellow?" And I said, "Sure." That was it. That was how I ended up doing movement disorders. And I found it very rewarding because, first of all, Tony is very, he really is great at doing a physical exam and really thinking deeply about a patient and not taking the obvious answer, but actually wondering, is there something else going on? And so that was a great example to be around. And also, you just follow patients for decades. And I liked that aspect. There are some people in neurology who like the very brief encounter. I liked following patients over time and getting to know them, getting to know about their kids, about their trips, about their dreams, about their past. Like, my patients have had way more interesting pasts than I have. They've done a lot of interesting things, and I always learn so much from my patients. So that was how I got interested and engaged in movement disorders.
And then what about the palliative care piece? Tell us a little bit about that and how you've been such a champion, because you've sort of been such a...
So when I first started on faculty, first I did community practice, and then I was on faculty. And at the time, nobody was talking about palliative care for Parkinson's. They would talk about where people died. but they wouldn't really talk about what do we do when clinical trials aren't available for patients? What do we do after they've had deep brain stimulation and they're still having problems? And so I thought about doing palliative care and bringing a different approach to patients to look at not just the scales that movement disorder neurologists love and complete at every visit, but thinking about the other aspects of their condition and how could we make their lives better. And I would say this was early in the 2000s, and people would tell me, that's stupid. Don't talk about it. Or that's not necessary. Don't talk about it. But the reason why I persisted was two things. I approached a neurologist who was also a hospice director and asked him if he thought it was a good idea. And he said, absolutely, that's a wonderful idea. And then the other source of support was from nurses. The nurses who often worked at centers of excellence, and they were the ones taking the calls from patients who no longer could come to the clinic. And they said, oh my God, that is so needed. That is so necessary. Someone should do that. I'm so glad you've thought of it. And I think those two sources of affirmation that, this is really something that is necessary helped me to continue on when everyone else said, please stop talking about it.
That's amazing. Well, here we are, I guess, 19 or so years later, and we started this, I guess, society on much, sort of piggybacking on all the work that you've done, and a few of other sort of, leaders in the field really kind of got together. So maybe you could tell us a little bit, Janis, because I think we don't want to spend the entire hour talking about palliative care, because I think you've sort of taught me so much about just the patient experience and quality of life and finding joy and meaning. And I want to hit on all those topics, but maybe we could sort of talk about maybe the palliative care principles and how I think we can actually use those in applying sort of our approach to living every day and thriving every day, from literally diagnosis, day one of diagnosis with, Parkinson's disease. So maybe you could tell us a little bit about the approach and then how you've kind of sprinkled it into other areas too.
Yeah, so the principles are that palliative care is applicable no matter what stage of illness. And some people are surprised because we associate it with end of life. And there was a great Simpsons episode. I do love The Simpsons. I think of myself as being like the little sister in there. And the doctor says, well, Homer, you're going to die. And goes and picks up a pamphlet that says, you're going to die. And he leaves him with the pamphlet and walks out of the room. And it's sort of that principle of palliative care is just for end of life. Well, it's not really. And to address people's questions and struggles that they have. And with palliative care, there's an emphasis on spiritual distress. And that is something that I think is really neglected in medicine. We don't talk about that a lot, right? Like people have very common questions or common reactions when they are faced with a serious medical condition. And for doctors, we sort of have this hierarchy of thought of diagnoses, and we think, well, Parkinson's, at least there's a drug to treat it, and at least we have surgery, so you won the lottery. But to our patients, it is not like winning the lottery. To the people with Parkinson's, it is a complete change in imagining themselves now and in the future. What are they going to be able to do? How will this change their roles as a husband or wife, daughter or son, mother or father? How does this change what they can hope for, what they will be able to achieve? And I think that it is so sad that medicine does not feel that this is our responsibility. I think it is our responsibility to help our patients navigate those questions, to even articulate it. Sometimes they don't understand why they're feeling so distressed, but to help them articulate that distress can be very helpful. And to help them then move forward from that, to be able to set goals that are achievable, to celebrate successes, and to find some peace and acceptance. And some people say, oh, acceptance, that's so passive. It's like so un-American, right? To be and accept. But acceptance doesn't mean you have to agree with it or like it. It just means you acknowledge this is what it is right now. And I think that when we can accept, it allows us space then to think of what is possible. And then the other aspect of palliative care that I think is very important is that the family is really the unit of care. Again, for some reason, many physicians don't really embrace that concept. And I think this should be throughout medicine, is that the family is the unit of care, because every person who is living with Parkinson's has so many people who are connected to them who are affected by the diagnosis as well. And that when we broaden our scope to the family as the unit of care, we can help the patient, we can help them explain to their support system what is going on, what to expect, and how to improve things. And when we ignore that, the family, when we don't include them and welcome them in, we are really missing out on probably one of the most potent levers we have to make change for our patients. The other aspect is that it is team-based. Medicine is moving so much to team-based care. And I don't want to exclude private practitioners because they can still have a team. A private practitioner can still make the effort to engage those people in the community who take extra time to learn about people with Parkinson's and to help them live better. So you don't have to have everyone like in a physical space. It can really also be that you have a network in the community of people who you know can actually help your patients.
Absolutely. That's amazing. Yeah, I mean, I think those are the sorts of principles that I also appeal to me. And I, as you know, I have a background in sort of integrative medicine, sort of this more kind of holistic approach to things. That's why the series is called Wholistic. But sort of, I think the sort of thinking about the whole patient, you know, and them in the center of this world that's around them, including their family and their loved ones and their community. And then the multidisciplinary team approach has been something that I've really learned a lot from the palliative care, you know, sort of universe, and have been trying to drizzle into, you know, sort of wherever we can in care in general. And I think that these principles can be applied even from honestly the day of diagnosis. And I do agree that I think there's, you know, getting the diagnosis of Parkinson's can be a life-changing experience. And I think that often we, you know, do a disservice by just sending people off with the notion that, you know, come and see me in 3 months or 6 months, start this pill. And we're, you know, often, and we're sort of cheerleading quietly for them, but we don't really give them the tools that can really equip them to then, you know, cope, accept, and sort of move forward in a proactive way. You know, so I think that those are all the reasons that these two fields kind of appeal to me as well. Janis, you mentioned spiritual well-being. Could you explain that a little bit? Because I think people, you know, don't quite understand. I think, you know, so much of our focus as Parkinson's disease doctors, as movement disorder doctors, is on tremor and, you know, stiffness or walking, the things that are obvious as neurologists and movement. But maybe you could tell me kind of what your approach is, you know, from sort of more of a holistic way. I know you collaborate with, you know, some of our colleagues in the UK about non-motor issues and all kinds of other folks all over the place, including, you know, the more spiritual side of things. So maybe you could sort of put spiritual well-being in the context of the bigger picture, and maybe tell us a little bit about how you like to think about that in a person living with Parkinson's, and even maybe how we can help, that aspect as clinicians and people who care for these patients.
So I think one of the first challenges whenever we talk about spirituality, people say, I'm not religious. That's a very common response. But religion and spirituality are not mutually exclusive. There are many people who do not follow a religion or attend church or temple or synagogue, but they still are spiritual. They believe in a power greater than themselves. And they also wonder, what is my place in the world? How have I made a contribution? What is going to happen to me? These are all spiritual questions. And I think that often, because we have become so dependent on technology, and we're all on Zoom, and as well as thinking about data analytics and artificial intelligence, we have somehow quieted that voice that is spiritual. And yet it is so important for all of us to recognize the spiritual within us, as well as being able to answer those questions about what is my place in this universe? Have I made a contribution? Can I continue to make a contribution? And I think that when physicians ignore this, they ignore a big part of the distress for their patients. It doesn't mean that we have to always address it or be able to have the answers or be skilled in guiding people, but to at least be able to recognize spiritual distress and to have team members who can help your patients is really important. And the way that the spiritual psychologist in my group has a conversation with patients is very instructive. We see our patients all together as a group, which can be intimidating at first, but the patients very quickly get used to it. And I think the benefit is that we all pick up something from each other. We learn from each other, and we actually get better in our conversations with patients and interactions with patients. And it has been very helpful for me because I take those lessons when I'm in the hospital, where things are much more acute and much more of a crisis. And those spiritual questions are even more heavy for the patients in the hospital.
Yeah, that's really interesting. So you actually have a spiritual psychologist on the team. Is there a questionnaire that they use, or is it open-ended questions? Could you give us some examples?
So we do use some survey instruments to get a feel of how the patient's symptoms are and the symptoms that are burdensome. And sometimes it leads from the conversation, but so we don't have a specific spiritual questionnaire that we put out and ask the patients to answer, because we feel that the 2 questionnaires are already long enough. And people feel sometimes that they're just like overwhelmed by all these questionnaires.
Yeah.
And inevitably in each appointment, there is something that she can touch upon or discuss, especially when people say in Canada, medical assistance in dying is a legislated right. And many times people are asking about it, and the reasons behind the question are more instructive than actually asking the question. And often the reasons are, I don't want to be a burden to my family. I am worried that I will lose my own autonomy. I am fearful of the future, not of what's happening right now. And a lot of those are spiritual questions. Some of them are medical questions that I can help them with, but many of them are spiritual questions And often, I'll give an example. One patient actually said, I don't want to be a burden to my spouse, and so I want to have medical assistance in dying. And she looked shocked. And I said, have you talked to her about it? Because she clearly is shocked. She clearly does not see that you're a burden. And she actually said, yes, there's still so much that you do as part of our family for our children. So it is important, I think, to pay attention to those cues and to attend to them, because otherwise you miss out on what's really happening with your patient.
Mm-hmm. Yeah, and I think that we're all so in a rush to just get the checklist done that, and I think we as clinicians feel like we, as the MD, have to do it all and get it all done. But it sounds like engaging other members of the team. Often when we've had some of these chats before Benzie came on and some of our other colleagues, people were really sort of amazed at the multidisciplinary team that exists in certain places that is around the palliative approach, but we're really sort of unable to really find something like that in their own communities. It might be helpful, Janis, if you don't have a doctor who's open to these conversations, to sort of help people get a sense of how they could bring it up, or are there other types of practitioners that they could engage, maybe outside of the neurologist if that's not available to them, or other resources that may sort of help guide them? Maybe you could explain that.
So it depends on your area. That's certainly true. I'll give you an example. In my province, we have primary care networks. So the family doctors actually handle a lot of the mental health issues. And many of them have on their team psychologists who can have brief periods of following a person if they are having symptoms of spiritual distress. So that's one source. I think many people don't think of their primary care physician as being a source who can help them with their Parkinson's, but that's one aspect. Another is if you have coverage or you have the ability to pay. Many psychologists are quite familiar with and comfortable with dealing with many of these questions. And some of them even have an expertise in dealing with people with chronic conditions where that challenge to your identity has occurred and you are struggling to find the meaning and purpose in your life. And then in Canada, we have an actual association of spiritual care practitioners. These are not necessarily religious people, but people who have been trained in spiritual care to discuss in particular these questions of distress, and as someone put in the chat, existential distress. So that question about meaning and identity.
That's good. That's great. So I think that's really a good sort of place to maybe discuss a few other sorts of things that I know you've had written some papers around and have been topics that have come up on. I know we're all on Twitter a little bit and social media, and these things come up, and patients are unclear of really how to contextualize this in the Parkinson's sort of world. One thing that has come up recently is the concept of demoralization. Could you talk a little bit about that, Janis?
Yeah, so demoralization is very separate from depression. Often families identify depression in the person with Parkinson's. But when you ask them the person with Parkinson's questions, in fact, they don't have signs of depression. What they really have is demoralization. And it's understandable because this is sort of a common scenario. You have Parkinson's and your doctor tells you to take your pills on the schedule, to eat a proper diet, watch your bowels, and exercise. And you do all of that faithfully. And yet over time, you still get worse. And that doesn't seem to be part of the social contract in medicine, right? You're supposed to follow instructions and get better, not continue to deteriorate. And that can be very demoralizing to people when they have put their best effort forward They've used all the resources at their disposal. They followed all the instructions they can, and yet they feel demoralized or hopeless. And so demoralization, I think, happens very commonly in Parkinson's. It probably happens at the times of transition when people are not doing as well, if they've had a recent hospitalization, or if they have a new medical condition with their Parkinson's that they're coping with, or they are experiencing cognitive changes or behavioral changes. And so I thought about this quite a while ago and wrote about demoralization versus, did a little study on demoralization versus depression. And in fact, the patients were largely not depressed, but a large majority of them were demoralized. And this has been written about by other people as well. And I think, again, this speaks to the need for mental health supports for people with Parkinson's, to help them make sense of this, to help them understand that even though traditionally we think that following the doctor's instructions should lead to a cure, there are in fact very few illnesses that medicine cures. Like, I want everyone to think about how many illnesses they know that medicine cures. It's in fact very small. It's like infectious diseases. That's essentially it. Because even people with cancer, when they say cured, to the cancer doctor, that means you are disease-free for a certain period of time. But you know, the average life expectancy of an American is 76 years. In Canada, is 81 years for men and 84 for women. So people have an expectation that they're going to make it at least to that average life expectancy. And so we often don't consider that even if we made our best effort and we got worse, things would probably be much worse if we hadn't exercised, if we hadn't socialized, if we hadn't done all those cognitive exercises, tried to read and debate politics and be engaged in our community, we would be much worse off.
There's a question in the chat, Janis, about how we differentiate demoralization and depression. Do you want to briefly touch on that?
Yeah, so depression is a constellation of symptoms where, yes, you do feel hopeless, but there's also an inability to feel joy. So activities that previously were enjoyable for you are no longer enjoyable, that you are tearful and crying often, that you are unable to engage in social activities because of lack of motivation or your mood. Whereas demoralization is that hopelessness, that sense that no matter what I do, things aren't going to get better. And I think if we allow our patients to sit in that space, instead of helping them to see it's not going to get maybe significantly better, but you are doing everything in your power to keep yourself from deteriorating much more quickly. And we have all seen that as physicians, but also the people with Parkinson's who have attended support group meetings. You've seen the people who somehow 20 years in, they look really awesome. And the other people who have been attending the support groups for a very short period of time and have deteriorated much more quickly. So I think we have to change in our minds and in the minds of our patients, what is success?
Absolutely. Another question is, whether, so maybe when we're trying to help patients cultivate joy and sort of the flip side of the, like, lack of hope, and trying to understand how to build hope or find joy and meaning. What are some ways, maybe practical ways, Janis, that you've been able to sort of help guide patients? Do you have any sense of how to do that?
I think a big part of that is goal setting, because goal setting gives you meaning. It gives you an anchor. And when you achieve it, it gives you a sense of accomplishment. The other is to find joy in small things. I think we have all had to do this in the past 2 ridiculous years of COVID, to find joy in small things, right? Like that loaf of sourdough bread that we all learned how to bake sourdough bread. And the way it smells so fresh out of the oven. And when you cut into it and the steam comes up and you just think, I created that. Like, how awesome is that? To take joy in everyday things, it is very impactful. So throughout COVID, there were reports of little projects on joy. And it was, they asked people to go on a walk, and on their walk to take a picture of themselves when they felt happy in the walk. And the act of having to consciously think of that and take a picture of themselves and document it helped them to realize, even though there were so many restrictions in their lives, there were moments that they felt joyful. It could have been seeing something in a store window, stopping off and getting your favorite coffee, hearing a bird sing who you've never heard that song before. There are so many ways to find joy. Someone has written about a gratitude journal. That is absolutely true. A gratitude journal does help. It's interesting. The research shows that doing it daily is less impactful than doing it periodically. And so periodically to write down things that you are grateful for. I think in society today, there's so much pressure to be perfect and to have a picture perfect life that we rush by in the pursuit of that, and we do not appreciate what we have right now. And for us to be grateful for what is today at this moment is important. Doctors are extremely guilty of this because we're always thinking about the next paper we're going to write, the next big grant we're going to get, the next big title we're going to add to our name. But to instead to enjoy that journey, to enjoy what is happening now, I think is very important.
Absolutely. People are writing about mindfulness. Yeah. So I think some of the stuff about just sort of staying in the present moment. And I haven't told you all this yet, but I ended up applying for and getting a fellowship through the New York Zen Center for this year for healthcare providers around a lot of these topics, mind-body approaches. And so I'll be working this year to learn more and come back with some new knowledge. Really a lot of reading, a lot of beautiful things, connecting with providers just like me throughout the world. And it's been already a great exploration, and just taking the time to pause a little bit and to just reflect and to be in the moment and, have that cup of tea and smell the, the spices in there, or the, to look at something beautiful or to feel the sun on your face. Sometimes it's just these little things that make life so rich. So I think that it is something that I think we're really all in it together. Even us as providers, we're all trying to figure out, how to find that balance, because many of us, I think, went into the field to really connect with our patients and to, hold their hand and walk alongside for, these decades that we follow our patients, which is a beautiful thing with Parkinson's. But I think we're trying to figure out the balance given all the things that are happening with COVID and mental health, even in our own spaces and in our own worlds of burnout and, colleagues that are also having some suffering. So I think, we're just, all sort of in it together. Wow, the chat's going a little crazy. I'll have to catch up with all of these messages. But Janis, One thing that I wanted you also to be able to speak about, a few things. So one is that you mentioned, who are those people that you go to these support groups and they look like they're just really thriving, and they've sort of, something about them. It's sort of what I've been terming the secret sauce. What is it that really helps people succeed, or do well or thrive after they get the diagnosis of Parkinson's? And you've done this, I think, for longer than I have. So maybe you could teach us those pearls that you've learned.
And I want to be careful that it's not just the physical aspect, because some people think it is, if someone is physically not doing well, then what a sad thing, what a tragic thing. And I remember one of my most positive patients, she was a professor of bees, which is an interesting topic. And she was quite disabled. She was wheelchair bound. And yet every appointment, I asked her how she was, and she said, just wonderful. And she always had something great to tell me about. She was definitely very grateful, but also her husband was so wonderful at knowing what things would be joyful for her. So he and the paid caregiver they had organized teas for her former students. So they would come from all over Ontario and have tea at her house and tell her about their research on bees and what was happening in bees. And she would be having tea and petit fours with them. And it was wonderful, to always have that upbeat spirit, even in the face of great suffering. So I think one is attitude, and some people are just born like the glass is half full, and others are the glass is not full. So I think one of that is your personality to begin with, but also the people around you, when they are able to do things that, instead of saying, oh, poor you, or why don't you get up and walk, get up and walk, get up and walk, get up and walk, get up and walk. But instead, what can we do that's going to be something to look forward to? And once it's done, something that you really relished. I think that is a gift, to be able to do that for your loved one. And then her, just how much she enjoyed younger people, like younger people really give you that zest, right? They are inquisitive, they're energetic, they're enthusiastic. And I think the opportunity for her to have young people around her was very helpful, even though they never had children of their own. Her students were their children, and they were able to leverage that community to help raise her spirits. So I often think of that patient when I'm thinking of things that help people. The other is connections with your family. Whenever someone says, I don't have any relatives, I don't have any close friends, I don't have close neighbors, my heart kind of sinks a little, because it really does help to have that support network. When we are isolated, things seem so much worse. And when we are connected, things that previously seemed insurmountable are bearable. And so I think that social connectivity is very important. And with a group of people who take you as you are, some of my patients are previously very high achieving CEOs and lawyers, and their friends are very kind, I have to say. Some of them have come back and they've said, my friends don't want to play golf with me because now my golf game is so bad. And I'm thinking, and I said, you need to get different friends.
Yeah.
I think we also need to look at the support that we have, and if it's actually helpful or if it's kind of a drag, and sometimes if you have changed and if you've done the work to actually emotionally evolve too, and they have not, then you need different friends.
Yeah. Yeah. No, I think social connection is so huge. I mean, it's been something that I think we haven't really spent any time thinking about. As physicians, I certainly didn't learn about it in my medical school days in Toronto. We talk about everything but things I think that's ultimately that I find are so important when we're in those 4 years of medical school. We're learning about the Krebs cycle and all this other stuff. And I never learned about how important sleep was and, hydration and social connection and, basic things. So I think it's just so key. I think your chats about demoralization are really resonating, all this sort of, figuring out ways to, find meaning have really resonated. And I think that those are, these are things that we don't talk about. This is sort of a space that we've sort of brought it up, but I can't tell you the last time I heard any of this at a meeting about Parkinson's, let alone, for patients. So I think it's just we need to do more of this. Another question, Janis, I think similarly, so we talked about the patient. How about the caregiver? Maybe I know you've done so much work in the caregiver space, and I think you and I both feel that you can't, help patients without thinking about, who comes alongside with them. So teach us a little bit about your sort of approach to helping caregivers and, what makes them thrive, and also maybe what about quality of life for patients, and really what leads to a good quality of life for patients.
Yeah, so first of all, people with a caregiver do better. So that was one of the papers I wrote, because I really did feel I had this bias that it was true. And when we looked at our large study, in fact, it was true that people, even though they had more motor symptoms and more cognitive symptoms and more mood problems, they actually did better if they had a caregiver, and they reported less spiritual distress. And so I think the caregiver, even from that one piece, you can tell that a caregiver is really important. And I do use that word caregiver because in our group, it was a palliative care group. So at that time, they're less of the partner, and they are having to take on some of the decision-making that's required without sometimes the input of the patient, because things have changed so much in the relationship. And so many of them did say, yes, I do identify as a caregiver. I think the spouses and care partners of our patients are important. And when they do well, and when they are well informed, and when they can be supportive to the person with Parkinson's, it makes a huge difference. I've also had the opposite experience where the spouse was not very accepting and helpful. And then in that instance, it can be equally damaging to the person with Parkinson's, because this is your closest relationship, and to be rejected by someone or to be criticized by someone because you have a physical illness must be devastating. So the care partners can be equally helpful or equally hurtful. And it's important for the team to support the care partner, to give them the information they need to see what's happening, to see what might happen, to prepare for the future. And I think also to be their support and to be a little bit of a cheerleader. I think one of the most important things I say to care partners is, you're doing a great job. The number of people who turn around to me and say, I'm not, is surprising. I've learned to be less surprised over time. Inevitably, most care partners say, I'm not, because they feel there's so much more they could do, even though they're exhausted. They feel they could do it better. And I think it's out of love and frustration over Parkinson's that they have these feelings. And so for the team to be able to say to the care partner, you are doing a good job. Nobody's perfect. This is the first time you're walking this road. How can you possibly know everything and do everything? And how can you possibly be patient 100% of the time? No human being is patient 100% of the time. I think it is important for them to hear that, and for them to feel that the physician feels they are doing a good job. I think that's the other, although this is directed towards patients, I think many physicians don't realize how much our patients look up to us and want to hear how they are doing. And that goes for the care partners as well. And so when we say things to our families, like, you know, your mother always is dressed so beautifully and her hair is always done well, and, you know, she just looks so happy. It makes them feel good about this very challenging job they have.
Absolutely. I mean, I think then COVID has been extremely hard on our caregivers as well. And I think, you know, it's hard to acknowledge that sometimes when there's so much craziness on Zoom or we're doing a virtual meeting and it's, you know, there's just like so much to cover. So we see you, and we, you know, our thoughts are with you all, and, you know, hang in there too, and take care of yourselves as well. I think that's so important. So, but I think, yeah, just saying these things out loud, sometimes they seem kind of obvious, right? But we as doctors probably don't take the time, and it's good, you know, everyone wants to hear that that we acknowledge that they're trying their best, and that they're doing a good job. So, Janis, could you tell us a little bit about the SHARP program? Could you tell us what that is?
Yeah, so that was strength, hope, something for people with Parkinson's. Strength, hope, and resilience for people with Parkinson's. And it was based on a positive psychology framework for people with chronic pain and at times drug addiction to opioid analgesics. And the principles are quite universal. It's to one, to think about things you're grateful for, to be able to imagine a future in which you can participate and you want to participate. And to also articulate the skills you have learned that help you live with your condition. It occurred over 6 weeks, and it was led by 2 psychologists, so it was pretty intensive. And it did show that the group that had the program earlier compared to the waitlist group did improve, but just being on the wait list improved you. And that's probably because it's based on positive psychology, right? The idea that I am going to get help is itself a powerful tool to help people feel better about their condition, their situation, and the future. And so I think that the lesson from that is your mind is a powerful thing, and that we can change how we think. It is also true that a large number of the people who participated were already highly motivated people who were on the whole more positive than I would say the average population. So it did attract a group of people because they heard, oh, strength, hope, and resilience, sign me up. And so you attracted a lot of people who already viewed those as important qualities and had already done a lot to cultivate it in themselves. Because we did interviews and they were very sophisticated in their articulation of what they got from the program and also their personal philosophies about hope and resilience.
Interesting. So I would love to. We have about 8 minutes left, Janice, and this has been a really, really cool conversation. I think very out of the box, as I hoped and expected from, us both talking about these things. I want to give you some time to tell us maybe what I think we're sort of at a bit of a crossroads, right, with the pandemic and sort of how we're going to move future in medicine. And I know you've been a thought leader, and you're getting more and more involved at the AN level, like really high up in the echelons of leadership there. What do you envision as the needs, and also how to maybe a few low-hanging fruit of what you really see that we can accomplish in medicine to help people living with Parkinson's in 2021 and beyond?
Whoa, that's huge. Okay.
We have 8 minutes. No, I'm joking. We could just, start the conversation, but
I think a lot of it is what we've discussed already. It is helping our patients understand that the tragedy is not that they have Parkinson's. The tragedy is if they cannot find meaning and joy every day. I think to focus on these other aspects of care, to incorporate more of the patient's goals. And that doesn't mean we can always meet them. I think we have to acknowledge that, but at least to hear what those goals are, to try and help our patients see if they can reach it, and to make a plan to help them assess if they can reach it is really important. And again, I cannot emphasize the importance of having the family involved in care. So many times I hear, oh, well, my last doctor said my family can't come in. Oh my, that is really sad to me. That the family will have questions. And I know that, when my husband goes even to the family doctor for a routine visit, and I say, "What the doctor say?" "I'm good." I'm like, that's not helpful. And I know probably this is the answer that many people with Parkinson's give their families. "Oh, everything's okay. I got a prescription again." And having them participate in the appointments can help them understand what's going on, and at least help them understand things that have been offered to them, and reinforce that these things are good. So in my clinic, we offer physiotherapy and occupational therapy at the first visit. We get acceptance by about 20% of people. When the family member's there, the family member says, "I think that's a good idea. You should do that." And they say, "Okay, I'll do that." And so I think it's an opportunity too for the family to sort of voice their opinion and support for some of the things we suggest, and also to understand when it hasn't happened, why it hasn't happened. I think that we will have to provide more integrated care in terms of the family, in terms of all these other resources that are available, and that physicians need to start working in teams, and working in a way that is cohesive and consistent. I think that even within a single center, there is so much variability in how physicians practice that is unnecessary. And that if we can do consistent things that will help our patients and are low risk, like physiotherapy and occupational therapy, letting them know what are their government entitlements through the social work. All these things are very basic. They're low risk, and yet they happen infrequently. And so I think we have to start to use the team members at hand more effectively for our patients. We have to engage our family members more. And that I wish everyone actually approached their patients with palliative care skills.
Absolutely. Yeah, I mean, I think that a lot of these interviews we've had, I guess, almost 100 or something, Andrea and I figured out in the last year, boil down to the same sort of things. It's sort of like finding meaning and purpose, understanding what brings you joy every day and trying to go after that, right? It may not be what I think as a doctor you should be looking like, but if, you want to, be able to have a popsicle with your granddaughter or whatever at the, baseball field, then that's what I have to try to get you to do, and it might be different for different cultures and contexts in different parts of the world. And so we really have to meet people where they are. But then, these sorts of ways to think about, life and what the future holds, and to really preserve the things that are meaningful, I think, for the human experience going through it. And that social connection is so key as well. And then, finding choices that you can make every day to try to, incorporate, and the people that can support you to do those is really also something that we've really boiled it down. So it's like these few things that are, everyone says over and over. Tony Lang sort of said the similar things at the end of, a long chat. So I think these are universal principles. So yeah, and the palliative care, I think, principles of this holistic health with, all the pieces, including the spiritual, and then thinking about the person and their environment, and then these sort of finding meaning and these sort of wellness sort of strategies are so key. So I thank you so much, Janis, for taking the time. I want to give you maybe a minute or two to give, our audience some hope, and any last minute sort of things that you might want to say to our group here. But we've had people join us from Australia and Canada and all over the world, honestly. So I'm excited to see such a global kind of community coming together to hear you.
Well, thank you. And I think that hopefully, based on this talk, that you all think of things that you're grateful for today, and that you will see that there is always the opportunity to find meaning and joy every day.
Well, thank you so much. So I'm going to hand it back off to Andrea, but this has been great. And thank you for all the work that you've done. You've made it easier for us to kind of fight the fight on some of these, these sort of arenas, and hope to follow your footsteps, in the future. So it's just so nice to have a woman in leadership that is so embodied, I think. And I think that's come across, and people have really enjoyed sort of hearing your sort of human side. So we really appreciate that. Andrea, I'm going to pass it back to you to give us our goodbye wave to the group.
Yes, thank you. So Dr. Miyasaki, we always have a little moment of gratitude. I invite everyone to turn on their camera if you've had it off, and just show your appreciation for this brilliant session with Dr. Subramanian and Dr. Miyasaki, and just a little Zoom connection, no matter where we are across the world, always feels nice. So thank you everyone for your amazing questions, and thank you, Dr. Miyasaki, for coming on, and thank you, Indu, for hosting as always.
Thanks. Be well,
Bye,
everyone.
everyone.